Let's get started. So welcome to Lion's Den 2019. I'm Chang, and this is Kristin Rising. And how many of you guys have been to previous iterations of Lion's Den? Woohoo! Welcome back. So we are going to, do you want to introduce them at the end or now?
Let's
have you guys introduce
you might know all our
now.
lions, but let's just go through who we've got here today. We have no mics.
Okay. So I'm Ranney. I am an associate professor at Brown, and I do research on violence and mental health and the use of technology to facilitate public health.
Lynne Richardson. I'm professor and vice chair of emergency medicine at Mount Sinai in New York City. I do health services research, clinical research, a little bit of this, a little bit of that. Been around a long time. Glad to be here again. Thank you.
Hi, and I'm Jeff Klein. I do work in thrombosis and mentoring. I'm a PI of a K-12 program, and I am the editor-in-chief of Academic Emergency Medicine.
Hi, I'm Philip Levy. I'm a professor of emergency medicine at Wayne State in Detroit. I'm associate chair for research in my department and also assistant vice president of the university, overseeing translational science and clinical research innovation. And I already have a favorite team here, guys, so I'm not going to let you know who that is. But they're sitting in the front row, and they came here from Detroit to present to you. So I'm not trying to bias the audience or anyone on the panel here, so we'll see how that goes.
You're actually dissuading us.
Hey, I'm Sam McLean. I'm from UNC, and I do research on post-traumatic neuropsychiatric outcomes, MTBI, PTSD, pain, that kind of thing.
Great. So we have all seen kind of your traditional research proposal and how it's written. You've got your aims, you've got your background, your methods, which really is your analytic plan, right? You're submitting these to your various funding organizations. But really, what are you selling, right? You're selling yourself. And these are kind of the parts that correlate with what you're trying to sell. That your aims, that you're organized and focused, and that, why your study matters and why they want to fund it and why it's novel and important. Your methods tell them that you have a solution and that you have a plan of how to implement it. Your biosketch and institutional resources tells them that you're the right person to complete this project. And then your budget, right, that you can actually complete this within your costs and that you actually know how much it takes to complete this project. All right, I'm going to skip some of these because we have a couple more than proposals. So I'm going to tell Kristin, take over. I can't see. I'm too short.
All right. So an outline of what we're looking at here, right? I think hopefully most people have seen Shark Tank. If not, watch it sometime. It's actually an interesting and useful way to start to think about how you are selling proposals to people. But you want to know that there's an unmet need that matters. You want to convince the lions in this case that your solution is well designed, you're organized, and will work, that your outcomes are valid, reliable, and achievable, and that you specifically are capable of doing the study, right? And so our structure here is going to be very rigid because we will run out of time otherwise. And so each of the presenters has 5 minutes to present. I'll keep time and flag you down when you have about a minute left. Then we have 8 minutes of discussion and critique and any offers, mentorship or otherwise, that your lions want to give you here. Again, strict time limits. It sounds like it's possible the last person maybe didn't make the flight, so maybe there will be some flexibility for other talk at the end, but otherwise we're stuck to down to the minute.
She's here.
She's here. Never mind. Strict time limits. So a reminder for everyone here, these research proposals are still under development, so please respect the presenters who are working on them and don't take their ideas. So here's a list of presenters. I'd like to ask our first one to come up. I'm not going to introduce by name because I might butcher it, so you can introduce yourself. Tiger. Great. So come on up. And I'm going to show you this list one more time so that when you're presenting, you know you're the next one up. So look at the order, know you're the next one, and be ready for us. All right?
Sorry. To our AV person, can we get a second handheld mic, please, while they're presenting? Thank you.
just click from here? Quicker? Okay. Sure. Yeah, why not? Hello, hello. Yeah. All right. We're ready with time? Yeah, all right. So hello, everybody. We are Nutroit, a nutraceutical company based out of Detroit, Michigan. My name is Donnie.
My name is Suki. My name is Tiger.
And we're emergency medicine researchers out of the Detroit Medical Center, kind of focusing on extensively with cardiac disease and its outcome. And basically, we've sort of, being as a part of the research team, we've personally seen like the progressive worsening of symptoms that bring cardiac patients back into the hospital, whether they are from hypertension, heart failure, or heart attack. And so as many of you may already know, heart disease is one of the leading causes of death here in the United States. Leads to about $1 billion in readmission rates and 1.5 heart attacks annually. 50% of those are due to preventable lifestyle factors, what we found, and one of those lifestyle factors is nutrition. So kind of like talking to patients in the ED and working with specific focus groups, talking to those guys, we've sort of gotten the idea that there isn't much emphasis placed on nutrition of itself, and it's just difficult to kind of integrate nutrition into patients' lifestyles, whether it's like how to find the food, how to purchase it, where to go, and kind of like effective nutritional management. Some patients kind of understand the medicine that they're on, but many of them also don't understand the medications they're taking or the extent of their cardiac disease or their illness. So it kind of like fast forward goes into poor clinical emphasis, not only in the disease state itself, but in the effective nutritional management in the post-discharge period, 30 days for these patients.
So our research really focuses more on what the actual healthy diet has when it comes down to the molecular basis. So the micronutrient concentrations in the foods that the patients are eating. So we wanted to look at the relationship between the micronutrient profiles and how that relates to a 30-day cardiac outcome post-AMI. So we're actually conducting the first study to do this, and we're pending EMF grant funding for this study. And what we're really looking at is a micronutrient profile for these patients. And so what is a micronutrient profile? We're looking at specific vitamins, water-soluble vitamins like vitamin B, and fat-soluble vitamins like A, E, and K, and looking at their cardiovascular benefits, and then looking at the specific levels that these patients have for these vitamins, creating a micronutrient profile, aggregating that, and then seeing how does that really correlate to cardiovascular recovery. And so the outcome that we're going to be measuring is 30-day readmissions and mortality. The reason we wanted to look at 30-day readmissions specifically is because Detroit has 19% compared to the national average of 17.7. And so we're going to be looking at how specific micronutrient profiles can actually influence that 30-day readmission rate, whether it goes higher or lower.
And so what my two colleagues have talked about is what Nutroid is and the crux of it, this micronutrient profile. So I'm going to give a quick recap of why we chose this profile and what our plan is for the future. So what happened is we did these focus groups, we talked to all of these patients, and we realized that patients realized that nutrition is very important for the recovery. However, they couldn't get it, whether it was transportation, affordability, or even just the execution of that. So what we did was we planned out this study that we've now, again, pending for EMF grant funding, is that when patients come into the ED, we'll enroll them into our study, we'll draw blood from them, and spin it in a mass spec. And what we're going to look at is different vitamins, whether it's a specific vitamin like vitamin B3, or the distribution of those vitamins, which we've coined the micronutrient profile. And off of that, we'll be evaluating patient recovery time after the 30-day point. Now, why 30 days? So that in the future, when we implement this, as you can see in the 12 to 24 month, we want to put this in interventional means. So we chose the 30-day point because medication non-compliance is a huge problem experienced not only in Detroit, but across the nation. So we want to choose a recovery formula that can be taken for less than 30 days, so about a 1-month time point, and then see what recovery can happen. And then based off of that, we want to step a little bit outside of the acute cardiac care realm and see whether or not this can be implemented in different disease states. And then so to wrap this up, why are we here today? In Vegas, of course. Beyond just exploring the city, we want to be here to meet all of our judges. We want to meet everyone in the audience so that we can pave this pathway of micronutrient research and see what the possibilities are beyond just acute cardiac care. And then so why us? Well, we've already gained so much traction along the way. Not only do we have the amazing Dr. Levy, but we've also had two grants in our pockets, the MSSRF, which is from the School of Medicine, and after even creating this PowerPoint, the 1 week time, but we got another grant from the School of Medicine, and hopefully the EMF in the future. So to wrap up, thank you everyone for listening to our presentation. Thank you the judges for your time, and hopefully we can work together.
All right, I'm going to ask the first question. So just to clarify what it is that you're proposing, are you proposing a trial with giving people a micronutrient supplement, or are you doing an observational study where you're looking at existing levels in their blood and then tracking out outcomes and trying to correlate outcomes with micronutrients at the time of the MI?
It's both of those. So we're first starting off with the observation side, seeing the correlation between micronutrient profile of a patient presents with and seeing what the recovery is in the 30-day point. And then after that, we want to see how this profile works. Is it actually able to correlate to that recovery? And then be able to create a personalized form of intervention, whether it's like a vitamin packet that a patient takes for that 30-day point to hit that optimal level. And again, that depends on whether it's a specific vitamin that a patient needs or if it's actually a certain profile, like a certain distribution that has been shown across patients that correlates to this recovery.
But in this first study that you're proposing today, the kind of that you're talking about is looking at trying to see, is there any correlation between baseline nutritional micronutrient profile and 30-day outcomes? Is that correct? Okay.
Yes.
Yeah, so how stable is the micronutrient profile that you're going to measure? So if you get, this blood specimen, does it matter what I ate for the last day, 2 days, 6 months? In other words, can you really predict, is this a stable profile that I have, or is this something that simply reflects the things I've eaten over the last 48 hours? I have no experience with micronutrient profiles, and so I'm not sure this is even a viable idea yet.
No, sure. So first off, why did we choose vitamins? So we looked at there's obviously protein, there's vitamins, there's a lot of things that go into this category of nutrition. And when it comes to vitamins break down into, again, the fat-soluble and water-soluble. Water-soluble, you can pick it up, yep. And then the fat-soluble, they stay in your body. So one particular meal, we don't see that it should show a significant difference, considering the storage is, like, for example, B12 takes like months in order to leave your system, as opposed to water soluble. It depends on just how much water you drink that day, and it can wash out. So this hasn't been done before in terms of this micronutrient profile administration from taking it from the blood, spinning it, and see the profile itself. So from our past research, we don't think a meal should change it. But we'll have to see it in
So the profile consists only of fat-soluble vitamins?
No, and water-soluble ones, yes. We have a
Which are going to be more susceptible to recent intake, no?
Say that again, sorry?
The water-soluble vitamins will be more susceptible to recent intake.
They are, yes, because of the lack of storage. But we'll have to see how that works.
Do you have any way of establishing causation? I mean, this kind of reminds me a little bit of like creatinines post-cardiac arrest. People with higher creatinines, they do worse. So people that have worse nutrient profiles probably are sicker and can't eat or aren't hungry. So is this, how are you going to look at causation? Will it then be in the second phase when you start doing trials of different things to determine the micronutrient profile? I think you mentioned something about vitamin packs and...
Right. So this, kind of like we mentioned, is our initial phase for our research. There's a couple different phases we're going to be going forth with this, but for the initial phase 1, looking at patients' micronutrient levels and seeing a 30-day correlation between that and their cardiac outcome. So that being said, there's obviously a bunch of different factors that go into play, right? Like patient's lifestyle, medication, things like that. So with a micronutrient assay, taking those into account when we're enrolling these patients and looking at their sort of data and their sort of just what brings them into the hospital. We're taking that into account, but also looking at those micronutrients and seeing, is there a relationship between that with all those other factors into account as well.
I like it does stretch us and make us think about in new ways, and that I commend you on that. I would say that I would be more interested if you were addressing something that we could target that's more known. I was going to say, for example, metabolic syndrome and interventions to reduce known components of metabolic syndrome that are associated with atherosclerotic risk. It just looks like you're in a lifetime of research to even do the linkage of, and you haven't even named the micronutrients. I'll give you one, like folate, for example. A lot of people think you should measure erythrocyte folate to really understand the, the body's use of it rather than plasma. So it might be a long time before you really even get the part of the micronutrients. So I'm gonna have to pass on this in any way. I'm very interested in metabolic syndrome and thrombosis. So if you can find out a way to link those two things, I think that I could hook you up with some team members that would be interested in collaborating.
Okay. Thank you.
I think this is simply brilliant. So, now, obviously, we've talked a lot about this, and there's a lot of ways to go on this, but maybe you can help Dr. Klein understand a little bit more. How many micronutrients are you looking at, and what exactly is in the profile?
So with our mass spec right now, we have about 26 different micronutrients that we're going to be looking at within a patient profile. So the ones that we show in our presentation aren't the only ones that we're going to be looking at. Those are just a few that we selected that have specific, I guess, or more specific correlation with cardiac disease. But with the 26 that we have, taking into account all of those, we're going to look for at least specific correlation between, let's say, if this vitamin A has a strong correlation with someone's 30-day outcome, and another patient has a low vitamin A level, and their 30-day outcome is a lot worse. Taking that into account, looking at specific micronutrients, as well as the array of the micronutrients in general, too. So more than one, and one in particular.
Yeah, I just want to say really briefly, and just in terms of an NIH grant, so I think it's great. It's an obviously incredibly important problem, and a lot been written about huge disparities in nutritional access. I think if you're going to do an NIH grant, that my own recommendation would be to say, you need micronutrients where there was data that they were associated with outcomes previously, especially for your like vitamin D and another vitamin that are known to be pro-inflammatory or something, and try to link them both into looking at overarching hypotheses like around inflammatory systems. And we're going to look at an AIM-1, and hypothesis 1 would be about vitamin D, and another one would be about another micronutrient that has pre-existing data showing that it is associated with these outcomes. So there's a sort of a pathophysiology that people would be potentially involved that's been documented, and there's been documented associations with their adverse outcomes, and then getting a little bit of pilot data to be able to show that was the case in your data as well. And then I could imagine one of you could put in a K award, or one of you could put in a similar type of grant where there's sort of 3 hypotheses, and the first 2 are about those 2 things, but they tie into an overarching system, and the third is perhaps exploratory about these greater profiles. But it'd be critical that you'd have those pilot data in terms of pre-existing data with a specific micronutrient, and then also some evidence of directionality in your own data.
So I think Sam wins for not taking a breath.
Yeah, that's just my normal talking
And I also
speed.
think that Sam is clearly volunteering to mentor them. In terms of you just wrote out 3 aims, my friend.
Those strategic insights, at the level of that kind of strategy, I think that's really what I would know to say. And I think executing that strategy would be outside my bailiwick.
Are we allowed as sharks or as lions to say that we're nominating Sam to spend an hour on the phone with them, and just an hour on the phone?
Yeah. I'd be glad to talk to you guys, and obviously you've got this fantastic guy here, but I think just in terms of overarching strategy, I'd be glad to talk to you guys about my 2 cents anyway.
Thanks, Sam.
Please don't study vitamin D. I think the NIH is sick of vitamin D.
Nicely done, you guys.
All right, next we have Taylor McCormick on Pediatric Trauma Triage.
Okay, great. There's allowed to be cheering sections. That's okay.
Thanks, cheering section. I've never seen Shark Tank. I don't know any of you people, and I have no team, so we'll see how this goes, but I'll try.
You get a pity vote.
Thank you. That's what I was going for. My name's Taylor McCormick. I am from Denver Health and University of Colorado. I'm one of the junior faculty members, and thanks for hearing my pitch on pediatric trauma triage. To get us in, can you hear me okay? Okay? I am tall. To get us into the pediatric trauma triage mindset, I want you guys to imagine your favorite child. This is mine because she's obviously cuter than the other ones, but imagine your favorite grandkid, niece, nephew, neighbor, etc. And then imagine when she's 2, she hops over a baby gate and then falls head over heels down a flight of uncarpeted stairs. It's not clear whether she's seriously injured. She's screaming. She's covered in blood from her scalp lac. 911's called. The paramedics arrive, and they load her into an ambulance and have to decide whether they're going to drive an extra 30 minutes across town to the Pediatric Trauma Center or if they're going to go to the ED that's just 3 minutes away down the street. So we know that if she's seriously injured, she's going to have better outcome and mortality if she goes to a pediatric trauma center, but we also know that you can't send every injured kid to the pediatric trauma center because we don't have the resources for that, and we want them to still do a good job. So the way that we decide, the way the paramedics decide right now where kids go in this situation is based on this American College of Surgeons CDC field triage guideline. There's physiologic criteria, injury criteria, mechanism criteria that help the paramedics decide where they go. This has sort of been widely adopted by EMS agencies across the nation. It's based on expert opinion, mostly targeted at adults, but there are 2 modifications for children, just for respiratory rate in the physiologic section and then fall height in the mechanism section. It has been prospectively validated. There's some serious limitations to the way that that was done, and that's something that I would like to get at. But to our best guess at how sensitive this is, this 2-year-old kid that fell down the stairs, that if she's severely injured, you really want her at a pediatric trauma center, we think these guidelines are about 65% sensitive for identifying that she needs to be there. So I think there's some work to be done in this problem. So my proposal is to conduct a population-based observational study that combines pre-hospital trauma registry and ED records to estimate the true sensitivity and specificity of these guidelines, and then evaluate the impact of adding an age-adjusted shock index criteria to increase the sensitivity of the guidelines. The primary outcome is going to be a consensus-based criterion standard definition that was published in 2013 in order to standardize research in this field with secondary outcomes of ISS, emergency operative intervention, and multi-organ failure. So why me? I'm a little bit of a rare bird because I did an emergency medicine residency followed by a pediatric emergency medicine fellowship, during which I got a master's in health services research. So I'm sort of in this lonely space where there aren't very many other people doing these things, but I think I'm uniquely suited to answer these sort of questions. And then I got a job at Denver Health, and Denver Health has a record of sort of leading in trauma research, but also has a unique setup where the division of the paramedic division sits within the Department of Emergency Medicine and makes sort of investigation and linking EMS data to outcomes data easier than it is probably in any other situation. So I think that I am the right investigator in the right environment. So what I'm asking from you fine people is just a little bit of sage advice. Is this a good idea, bad idea, ways that I should tweak this proposal? I need some time and money. If you have any of those things, that would be great. And then more than anything, welcome mentorship or suggestions for other mentors that would help further this work.
So let me open up by saying in my K-12 program, I mentor a trauma surgeon named Peter Jenkins, who is interested in a similar concept in elderly folks. And he's using the TQIP database. Are you familiar with that, and is that going to be part of your armamentarium?
It will be part of what I'm trying to do is get all outcomes. So TQIP is sort of a... They can't hear me. TQIP is going to have all of your sort of trauma registry patients. I'm trying to get at the entire population of injured people, which has been the hard part, but absolutely from the sort of quality database perspective, TQIP would be a major resource for me.
So as an absolute minimum, I need to connect you and Peter because you need to work on reciprocity starting now. I mean, you know, he has nothing against children.
I like old people.
You should.
I have grandparents.
They're both very cute. They're both harmless, and so one other thing.
Maybe your kids are harmless.
Yeah, they're now grown-ups. The one thing that I also think is interesting that I might just add to the mix is, will you be looking at non-trauma hospitals? Since a lot of mistakes happen at non-trauma hospitals. I'm not picking on non-trauma hospitals, it's just a fact. If you look at the numbers, many of the errors happen. So will you be able to include those in your database?
Yeah, so I think you can't do this without getting at the non-trauma centers because you don't know what your true under triage rate is if you don't have your whole pool of patients that are being transported. So that's what makes this so difficult, is that, so in Denver, for instance, we have Denver Health as a pediatric trauma center, Children's as a pediatric trauma center, and then there's 4 other community hospitals that receive kids by ambulance that aren't trauma centers, and I'm going individually to each of those IRBs trying to get patient outcomes from there, and it's really tedious, but I think I have to get that data to answer this question.
So I'm actually going to suggest off of that, and I'm going to kind of put on my Rhode Island hat here, which is that you want to work with an HIE, right? So a health information exchange, which is statewide and has data on patients who present to hospitals across the state and has outcomes data. I know Keith Coker presented on some of his work in Michigan. Certainly in Rhode Island, we have a NICE HIE, which has some good data. I have some PEM colleagues who I could volunteer connecting you with potentially. But I think to me, that would be a much easier way of getting kind of, now the question is, would it have the data to calculate your shock index? I don't know that. It really depends on the HIE, but that would be kind of my 2 cents, but I think it's super cool.
Your HIE where you are, it has outcomes and pre-hospital information linked?
So it doesn't, so we have a separate pre-hospital database, which is just become electronic and that we're starting to work with. So it's the challenge of matching patients is a whole different challenge, right? And so if we had Craig Newgard up here, he would talk wisely about that. But I would also say that Craig and the folks at OHSU should be someone that you should get linked to, maybe within the K-12 world, but can facilitate intros.
Well, thank you very much. Appreciate that.
Yeah, and where are you in your trajectory? Are you new faculty now at Denver, or is that where you are?
Yeah.
I think strategically, I have just a thought or two. I don't know much about this area, but one thought is I definitely would talk to and get to know as much as possible Ian Steele and have him as a consultant on your thing, because he's just like a world leader in developing these clinical prediction rules. Second thing is, I think that for your K award would be about, you'd have to demonstrate or have enough evidence that that there was a gap, that the current way that this was triaged was problematic, and then your K award would be about how are you going to develop, what are going to be the tools and skills that you need to further develop, in addition to your master's degree, that would allow you to start to develop these large-scale data collection efforts that will allow you to derive and validate a rule. And I don't know if I would close in immediately on the shock index or not. I think I might be more agnostic and say, during the K award, I'm going to look at these types. These are my candidate things that might help me, but I'm really going to want my K award to be about learning how to do this work, which is going to involve this small pilot of data collection and then this obviously very large-scale stuff in the setting of an R01 or beyond.
To maybe add one point just to push you a little bit, are there enough bad outcomes that you're going to find to really be able to tell a difference? So how sick are the kids that are coming in? Because I know at our children's hospital, anybody who stubs their toe gets a trauma activation, and everybody can, descends on the room. And so I think you might have to figure out first how expansive you need to be for your data before you start to figure out what the elements you're looking at.
I think it's going to be a huge problem. Looking just from like 2011 to 2018, which is sort of what my study period is right now, we have like maybe 50 kids at our center that were pretty seriously injured to be working with, but we'll have a few more from across the street and that kind of thing. But we're talking about like dozens and hundreds, not thousands, certainly.
Yeah, so the challenge will be then your likelihood of showing a difference or being able to affect outcomes regardless of what happens is going to be pretty small. So,
Pediatric.
Yeah, I don't mean small pediatrics, but
Yeah.
but I think to Jeff's point, you get a lot more power when you start to look across the age spectrum, even if you're carving it up into different segments. But sounds like great stuff.
Well, thanks.
So we had a couple of mentorship offers, some connection offers, any other offers?
I'd be more than happy to help you out with the Michigan Health Information Network.
I'll just say I think you have a lot of the components of a successful K award. Despite like our concerns, there's some things you need to address, but you have a lot there already.
All right, we have Stephanie, also from Brown. So we have, are you going to advocate?
Of course I am. She's got someone in her corner already.
All right, let me just.
Okay.
Hello, everyone. I'm Stephanie, and I'm a Global Emergency Medicine Fellow at Brown University in Rhode Island. Can you all hear me and see me? Okay, there we go. First, I'm going to start off with asking the Lions with a question. How many of you use or have or are wearing an Apple Watch or a smartwatch or a Fitbit right now? Great. How many of you treat patients with sepsis? Excellent, great. I think I might have you interested in my research project. So I'm going to be presenting my proposed research project, which is mHealth for sepsis prediction in resource-limited settings. So obviously, sepsis is a huge problem worldwide. We treat it all the time in the US. It is a huge problem, especially in low and middle income countries. So sepsis mortality is high everywhere, but disproportionately high in resource-limited settings in low and middle income countries, which is where I do a lot of my work. A lot of these are in pediatric patients especially. So we know it's a problem. It's especially a problem that disproportionately affects patients in low and middle income countries. What are the reasons for this? Sorry, that didn't come out very well. But obviously many problems. There's overcrowding. There's limited health care providers. There's not enough medications. The list goes on. One of the areas that I'm hoping to target is actually just in monitoring and identifying patients who need the most care and looking at the gaps in identifying patients with severe sepsis and seeing how we can intervene earlier. So this is just one of many areas that we can intervene on for sepsis care and sepsis patients in resource-limited settings. And so I'm just tackling this one portion and seeing if we can use some really cool new technology and to see if we can actually save lives. So I'm going to just start with a little brief story. So I worked mainly in Rwanda, but also was in Liberia earlier this year doing some ultrasound teaching. I was just rounding with some of the medical residents in the kind of impromptu emergency department at JFK Hospital. It's about 30 beds. They're completely disorganized. We were just rounding. I happened to round on a patient who basically was obtunded, checked their pulse. It was in the 180s. They were in profound septic shock. I looked at the chart for the patient. The last time they'd had any vital signs checked or documented was 12 hours before that. Patients, I mean, it's not that the healthcare providers there aren't doing their job. It is just completely overwhelming. There aren't enough healthcare providers. There's no conception of a telemetry monitor for even your sickest patients. And I saw that there was a huge opportunity that we could intervene and improve monitoring and identification for patients with sepsis. So can we use mHealth technology for sepsis care? There's a lot of cool technology out there. So a lot of us have a smartwatch, a Fitbit, what have you. There's also biosensing patches, which can actually connect to your smartphone. And this is a picture. This is a picture of the display of a smartphone recording a patient. Actually, this is a patient in Rwanda. So it's a biosensing Band-Aid patch that sticks to your chest wall. It can do 2-lead ECG. It does heart rate, respiratory rate, oxygen saturation, skin temperature continuously, transmits it via Bluetooth to a smartphone. And my idea is to see if we can create a personalized early warning score system using this technology for patients that, you know, we obviously can't use this for everyone. For patients that are very sick that, you know, ordinarily we would put them on something like continuous telemetry, monitoring, they would be in the critical care area, but in places where they're just, you know, tucked away in a corner in a busy ward, the idea is to attach these to patients, and this is what one of them looks like, and actually use machine learning technology to create personalized early warning systems for each patient, both just as a measure of if this patient has, you know, severely abnormal vital signs, but also to predict sepsis outcomes, including septic shock, need for multiple IV fluid boluses, as well as vasopressors and so on. Why am I qualified to do this? So I've been doing a global emergency medicine fellowship. I have extensive clinical expertise in sub-Saharan Africa and also Central and South America. And I also conducted the first pilot study validating the accuracy of wearable devices in a low resource setting in pediatric patients that was conducted this previous fall, and that showed excellent accuracy for heart rate, respiratory rate, temperature in patients in Rwanda. Thank you. My ask is for mentorship and collaboration with experts in digital medicine and also in sepsis care and providers in low resource settings.
As someone who doesn't know a lot about those areas, the one thing I would say is I think it's really important in making your pitch that was wonderful, but what came to mind when you described this chaotic setting is, what's the gap? Is the gap that there's just way too many people to ever treat or deal with? And so it wasn't clear to me that the identification would be enough to change the outcome. And I think that's a really important thing to hone in your argument for your grant, is that if these patients could be identified, actually outcomes would change. And it's not that it's overwhelming on 15 different levels, and it doesn't really matter if they're identified because there's, way too many.
It does matter. So you'd be surprised that a lot of patients don't get even simple things like an IV. Patients don't get IV fluid boluses, even IV antibiotics. So part of the gap, there's obviously many gaps. This is just one small component, but just the identification and actually triaging the scarce resources that you do have, which may just be, for many hospitals, capacity to do IV fluids, broad spectrum antibiotics, making sure they don't get volume overloaded. That is enough in many places that surprisingly can make a difference and save lives.
So you applied machine learning to a condition that is inherently associated with bad outcomes. And so you're kind of the opposite of the last one we talked about. You have so many bad outcomes in Ebola patients. Do you really need to use machine learning to predict what that is? Are you overcomplicating it by adding in a way to analyze when you know there are problems? So if you don't measure someone's heart rate for 10 hours and the first one's 80, the next one's 160, you got a problem. But if it starts to climb up as you're going through it, I don't know that you need in-depth machine learning analytics to figure out where the problem really lies. So I would say you want to avoid overcomplicating the message that you're delivering here. Just putting this patch on patients in Rwanda and capturing information that wasn't captured before is probably as valuable as anything. So sort of simplifying this message, I think, might have broader appeal.
I completely agree, and this study would actually be in two parts. The first would actually just be looking at pure vital sign, essentially a replacement for telemetry monitoring. Does that improve clinical outcomes? The second part is more fancy machine learning stuff to find those patients that are in the gray area that probably, honestly, even I at home don't necessarily have the capacity of seeing who's in this middle area. You don't know if they're going to get sicker. Maybe they're the people that get better. But absolutely, there's two parts to it. One is very simple, and one is a little more sophisticated.
So my reaction as I was listening to this, and again, I think it goes to the way that you craft the message, is that I hear you suggesting a very high-tech solution to be used in resource-scarce environments. And so in places where they're struggling with a lack of providers and a lack of resources, IV fluids, antibiotics, it's hard for me to, I want to hear the case for why we should take some portion of those scarce resources and buy these, wearable detectors, why that's a good use of scarce resources. I also have some questions about just how accurate the devices are, period. I heard, it might have been from you, that a lot of these personal devices are not very reliable in terms of the numbers. Now, maybe you don't need complete reliability. Maybe it doesn't matter if it's 120 or 180. But I am a little bit worried both about the technology itself, how accurate is it, and why you want to spend the money on this as opposed to, a system to improve, sanitation or something else that might actually have more impact on outcomes.
So those are great questions, and those are, so I think there are two parts. So the first part is it worthwhile to use like this fancy technology? This is actually very close to becoming commercially available and quite cheap. So currently each patch is about $20 each. In a few years, I've talked to multiple companies, they're expected to be less than $1 each. Most of the places that I've worked, this is obviously not generalizable to everywhere, but smartphones are readily available. This can run on any Android smartphone. It will soon be out on iOS. So it's not like people don't have smartphones. Pretty much every nurse in Rwanda that I worked with has a smartphone, the exact type of smartphone even that we used in our study. And as the price of these patches go down, as they become commercially available, as we start using them for when we go to the gym and so on, the price will drop dramatically. And it's actually, I think it's actually a great value for what it can provide. When you consider the cost of a telemetry monitor is upwards of $5,000, $10,000, $15,000 each. And people are trying to use them and are seeing better outcomes. And then the second part, I think, was about the accuracy. So that was actually the pilot project that I did this previous year. For heart rate, we were between 1 to 3 beats per minute compared to an experienced, trained Rwandan ED nurse that had about 10 years of experience doing manual measurement. For respiratory rate, it was between about 2 to 4 breaths per minute. And that includes in young infants who have respiratory rates up to 50, 60 breaths per minute. Temperature wasn't quite as good, but we're working on that. And as far as accuracy, more studies are needed, but I think for the purposes of most clinicians, I think those are pretty acceptable limits for for us, for sepsis at least.
Yeah, I mean, I think the gap it fills is in experienced providers to detect the patients as they're decompensating, and I think maybe focusing a little bit more on that in the pitch would have helped. I mean, I'm not sure, again, I'm not sure what your ask is. I mean, this is a pretty well-developed concept. You're in a good place, but.
Mentorship.
So I happen to know some people at Brown who do digital health. I also know people outside of Brown, so I'm not making an offer because I'm not allowed, but I'm just saying.
I don't know anything about I've never been to the continent of Africa, so I don't know anything about the resources where you are. I don't think I would be much help. I would only say one thing. If I were mentoring you, I would probably ask for, it's FDA cleared, right?
Sorry?
It's cleared by the FDA as advice
This one is, yes.
to monitor. I would ask about using it in nursing home patients to predict sepsis, try to use it closer to home. I see a lot of problems with data, trying to get the access to the nurses' phones, downloading data, privacy, consent. I just wouldn't even know how to help you over there, but here I would look at a high-risk population like nursing home patients and using this to monitor them. So it's just a suggestion, but I don't think I have anything to offer.
I'll be willing to help you out if you wanted to talk about machine learning techniques. We do a lot of this with chronic hypertension management and predicting population-level outcomes. I'm on the board that has a clinic in rural Uganda, and we do a lot of work to try to improve throughput and care there, so I'm happy to help you.
Thank you.
Sure.
Oh, you had an ask slide. All right. Next, we have Austin Kalaru coming from Penn.
Hello, everyone. Hi, Lions. This is the biggest room that I think I've ever been in. So I'm Austin Kalaru. I'm a research fellow at the University of Pennsylvania in the National Clinician Scholars Program. And my research focuses on follow-up from the ED and understanding the policy and payment systems that can improve our care coordination for patients that we discharge. This project is related, but a little bit different. It's something I never thought that I would be presenting today for you, but I thought it's crazy enough, and maybe my preliminary results are intriguing enough that it was worth sharing with you. So I need your help designing a pilot randomized feasibility trial to test home health as an alternative to inpatient admission. All right, it's a real case. Last week in our ER, Miss L, she's 76 years old, has a history of type 2 diabetes. She's homebound, lives with her family at home, has some chronic low back pain issues. 2 months ago, her primary care provider took her off insulin for some episodes of hypoglycemia. Consequently, she came into the ED with a glucose of 740. She had an AKI as well as some electrolyte abnormalities. What would we do for this patient? Admit, right? There's no way we're not admitting this patient to the hospital, except that we can't. Because on this night, the boarding situation in our ED was so bad, and the patients that we were having were so critical, that we didn't even have a team to present this patient to. So my colleagues had to manage the patient overnight. giving insulin, giving fluids, checking electrolytes. In the morning, she actually was fine. Her symptoms improved, her labs normalized, and what was the provider going to do? Well, I think if I was that provider, I probably would still admit the patient. It's a 76-year-old with a glucose of 740. That's like pretty high-risk patients to send home, right? Wrong. That's where I came in. So I was able to approach that ED provider and offer a suite of discharge services through home health by enrolling that patient in home health from the ED, including same-day nursing services, insulin teaching, telemedicine contacts with myself, coordination for follow-up appointments, and assistance getting to those follow-up appointments in terms of like an Uber ride. And we were actually able to discharge the patient home. So this is my core slide. So the problem I'm trying to address is that short-stay hospital admissions are costly and they strain hospital capacity. My research question is, can we discharge patients home that we would otherwise admit, and can we do that with enhanced home health services? And the study design that I want to try is a small, randomized pilot feasibility trial to test primarily the safety and the efficacy of an alternative home health discharge. And so a series of preliminary work that I mentioned. So I do have some funding from the Penn Center for Healthcare Innovation, some pilot funds. So I spent a week in the ED screening patients. Out of about 100 total admissions, we decided that about 22 of those 100 were eligible through some clinical criteria that actually could be managed at home. We approached the ED physician for those 22 cases, and we said, we have this service. Would you be willing to discharge a patient? We didn't say, like, would you be interested? We just said, we have this. Is this something that you want to do? And 13 of them said yes. Then we went to those patients, and we asked 10 of them, would you rather go home than wait another 6 hours in this emergency department and a couple days in the hospital? And 10 of them said yes. And this is all for data collection. We actually ended up discharging 3 patients without even trying to. And I mentioned these are some of the services that we can offer through my partnership with the home health agency. Same next-day nursing, repeat labs, IV meds, telemedicine check-ins, follow-up coordination, medical equipment, even a visiting doc, again, myself. And so this is what I need help with, Lions. Oh, not yet. I need mentorship, but specifically I need help designing a study, a small study that tests whether this is safe and effective. The research I do is primarily database research, and so I don't have experience in a kind of clinical operations trial. I also need help thinking about funding. So this doesn't really fit the nice NIH buckets. We're purposely broad in our disease conditions. So I think an R21 type mechanism might work here, but I can't, right now I'm not limiting it to a particular disease condition and institute. But could I approach payers, insurance companies with this proposal? Could I approach other groups like the Commonwealth Fund or people that might be willing to fund this? And then I need your honest opinion, because people at my institution are saying, oh, this is interesting. Like, everybody's interested. The hospitals are interested. The ED is interested. The Innovation Center is interested. But I feel like this is a little crazy. So I like your honest opinion. My final thought is that, are we good?
You're almost out.
Okay. Whew. Okay. Speaking faster than I normally would. So the question you're going to ask me is, isn't this just hospital at home? And for those of you who don't know, hospital at home is actually one of the most studied innovation care delivery models ever. It's been around since the 80s and 90s. And my answer to this is yes, it is kind of hospital home, but also it's not. Because really this is something that's a discharge to a service rather than admission to a hospital at home. And I really want this to be owned by emergency medicine. Hospital at home has had a lot of barriers in terms of its implementation around the country, primarily due to payment mechanisms. And this actually might be more appealing to payers and may be able to overcome the policy barriers that have impeded hospital at home. So with that, thank you very much.
All right, so I'm going to start with a couple of things, which is that I'm just going to kind of offer you anything I can other than money, because I've always wanted to work with you. Austin's like amazing. And I don't have the money, but I can also link you. So I can certainly advise kind of in terms of feasibility, like doing kind of, but I'm not an HSR person. But I do have 2 people at my shop. One is Jay Scher, who's my new chair, who is an RWJ scholar who does a lot of HSR things. The other is Liz Goldberg, who presented here at Lion's Den a few years back, then went on to get an RO3 and now has a K, looking at a similar program for geriatric falls. and preventing, and she's shown like an 80% decrease in repeat falls among people that get her community intervention program. And I think that it'd be super useful for the two of you to talk, both as peer mentors, but also in terms of developing some similar service kind of lines. And so that's going to be my offer to you. Is A, it's an excuse to finally work with you together, but B, to link you to Jay and to Liz. But you also have Zach, so you don't need Jay. So, but I hope he's not here.
I'm also not a health services researcher, but it seems like there's, you're riding the crest of value-based care, so there's a lot of interest from the health system on this side for people that are in a capitated type model. You're also for people who are Medicaid or who the hospital loses money on. If you pick one of them and one of a common condition in them, then you can get the hospital to fund it because they'll be interested in losing less money. So that's another route to go. The other route to go is to say, I'm going to focus and go this to NIA, for example. I'm going to make it about the elderly, and that way you can very much target an institute. You need to pick one or two common conditions, and then focus on a homogeneous pathway in a common condition that will be your focus of your, say, K award. I wouldn't go R21 because there isn't a real advantage of them. In my view, I think it would be a K award to a R award type thing if you were going to go the traditional NIH route, for example, rather than the HRQ or something.
Yeah, so I mean, this is not a crazy idea. It's also not a new idea. I think this is well past the feasibility trial stage. The problem is that a lot of the places that are doing this kind of innovation, and there actually are many across the country, are not necessarily in academic centers where they're writing about it. There's a hospital, for example, in New Jersey that's been doing this for at least 7 years. It's a discharge to home. No, it's an admit to home program, exactly what you're talking about. I did JediWise, I don't know, 6, 7 years ago, and it was exactly this, managing that ED to home transition with a whole suite of services, exactly what you proposed, done as a demonstration project on a healthcare innovation grant. So part of my offer, I guess, is to give you a list of people you can talk to so you realize this is not like a new idea that you just woke up and had, but in fact, this has been going on for quite some time. And I think there's a lot of evidence that it works, that it saves money, that it prevents admissions. Payers are very interested in these kinds of programs, and they might be a good partner for you. It's going to be a tough road to sell this at NIH, even at NIA. I mean, this is what they were doing, I don't know, 8 or 10 years ago now. They're doing something different in terms of research priorities. So, I mean, I can offer you some mentoring as somebody who's done quite a lot in this area and know people who are doing stuff in this area. There's no question this is the future of healthcare. We're going to be admitting fewer and fewer patients. Hospital at home, which you're right, is an old idea, has actually evolved into a whole suite of levels of care. We now, at my place, for example, have not only hospital at home, but SAR at home, an observation at home, all of which are available to me in the ED. So now there are all of these multiple destinations possible, and it's all from ED-based resources. You're absolutely right. So it's a great idea, but it's not a new idea. It certainly is an area in which you can build your career, and I'd be happy to talk to you about how you can do it, but it is not with this trial.
I agree, Lynn. I think this is, not only is it not a new idea, I think you have to hone in on your messaging. So it's one thing to send a patient home and check on them, and it's a whole other thing to provide a host of services that wouldn't have been provided in the hospital anyway, and now you're augmenting and doing a real home evaluation and service. If you want to do something where you're just checking on the patient and making the provider feel comfortable sending the patient home, that's a different ballgame. I won't feel more comfortable because they can get nutrition for the next 2 weeks. I'll feel more comfortable knowing a pair of eyes are going to be on them. And this problem has been tackled, or at least started to, by community paramedicine, where you are able to send a paramedic to the house to check on them the next day. The advantage here is that you don't necessarily have a billing code for doing that, but paramedics do. And so this has already been started in the state of Michigan with the Greater Detroit Area Health Council, and Rob Dunn, who I don't think is in the room here, but he's been working with them on this, creating billing codes for paramedics to go visit homes. And if you want to think of how you can force multiply, there's going to be 10 paramedics for every one of you that can go out and do this. So I think we would all feel comfortable if we knew a pair of eyes was going to be on the patient if they're not critically ill, but just think about what your messaging is.
Right, but it really is more than just having somebody check on it, absolutely. And there actually are care coordination billing codes now, so you can bill for these services depending on the discipline, social work can, nursing can, et cetera. So this has evolved tremendously just over the last 5 years, and you sort of need to get caught up with where the field is, so then you can figure out, now, how do I take it from there?
Right. I will say that I've been trying to catch up, and I've learned about the amazing stuff at Sinai. I know there's a large trial at Brigham, but I think I need to hone my messaging a little bit, and I think what I'm proposing may be slightly different in that it's not truly an admission, but it is maybe that pair of eyes, and it's something that is owned by existing kind of home health capacity, who has a lot of ability to do a lot, as well as maybe paramedics, but something that's not really a hospital admission.
Right, no question, but remember, there does have to be a handoff at the end of it. I think the trick to this is to embed all of those services and the, the FTEs to do it in the emergency department, because that's how you avoid the admission. When we started Jedi-wise, we used to talk, again, the patient you presented, 76, blah, blah, and I have 9 patients waiting, and the place is going crazy. It's like, just admit, and they'll sort it out upstairs, right? And they'll figure out how to get her home safely. And that became our mantra: don't just admit, call Jedi-wise. And we could get them home with services, home, visiting nurse, all of the things you talked about, IV services, teleconsult, all of that. So again, I know you're attached to your idea, but really it is about having this suite of services that you can implement from the emergency department, but then you have to hand them off. We're not going to follow them forever.
So,
Yeah,
I'm going to suggest that you take Lynne. So I think that one of the important lessons for those in the audience around this is the importance of being willing to morph your idea a little bit based off of expert advice. And so my bet for you is Lynne.
Lynne, I'd love to chat with you further. Great. Thanks.
So many slides. Kimberly? I'll leave the crying kid up here. That's a problem for everyone.
He's the man behind the curtain.
Look how Jeff takes directions. I've never seen that performance.
So good afternoon. My name is Kim Van Ryzen, and I'm coming from Indiana University Department of Emergency Medicine. I am Jeff Kline's research fellow. And I'm here to talk to you about a problem that we frequently encounter in the emergency department. So how many times have you guys seen the picture that's on the slide? Or how about this? Or shut the door quietly to the room as you exited to this. Well, I'm here to propose an innovative, holistic, non-invasive solution to decrease anxiety and pain and stress in our pediatric emergency department population, as well as their families. You ain't nothing but a hound dog, you're crying all the time. You ain't nothing but a hound dog. So everyone, please welcome Sue Grunfest and Pet Partners Las Vegas to the stage with Dr. Jeff Kline.
Please tell me someone's tweeting, because I can't get a good picture from up on stage.
So yes, therapy dogs.
We eat puppies, Lynn says. No, we don't.
All right, so welcome everybody to the stage. So our project, Canine 3, compares the effect of a 5-minute therapy dog interaction versus a control group, which is a 5-minute interaction with a child life specialist, on decreasing anxiety and pain perception in our pediatric population as well as their family members. So perceived pain and anxiety will be measured using the FACES scale that you can see on this slide, and they'll fill out both a pre and post therapy dog intervention FACES pain scale. Both the patient and the family members will fill this out. Additionally, to assess physiologic stress, we will ask the patient to wear this E4 wristband, which is a clinically validated galvanic wristband measuring heart rate, temperature, as well as skin resistance. Decrease in any of those can suggest decreased anxiety and pain. So why me? Why should you partner with me or be interested in this project? So we've completed 2 studies that have been accepted here at this SAEM 2019, demonstrating that therapy dog exposure decreased anxiety and stress in both adult patients in the emergency department as well as providers, meaning staff physicians, resident physicians, as well as our nurses. Secondly, we've already piloted this project at Riley Hospital for Children in Indianapolis. Across the board, we've seen that anxiety has actually decreased in our patients as well as their family members. But moreover, the greatest benefit was seen in children who have autism and other psychiatric disorders. And thirdly, we have applied for a HABRI grant, the Human Animal Bond Research Institute grant, as well as an NIH grant. We are anxiously awaiting those results that will come back in July. So come join our Canine 3 team, see a familiar face, Dr. Jeff Kline, as well as Dr. Alan Beck at the Center for Human and Animal Bond at Purdue University. And of course, the stars of the show are 7 team therapy dog handlers at the Riley Emergency Department. So what we are looking for are partners for a multi-center clinical trial exploring the effects of therapy dogs on anxiety and stress in our pediatric population and their families. A special thank you to Sue and her therapy dogs who are with us on stage. And I welcome questions and comments from the sharks. Or lions.
Yeah, no, I heard the ask. Yeah, we're in.
So the ask is, will you partner with
She wants
IU
sites.
for our multi-center clinical trial?
Wayne State is in too.
We're in.
I don't know. I have to talk to my med-mal people, but no, just kidding. I thought we would love it. I was too distracted holding the dog. I was like...
But it reduced your stress.
Oh my God, yes. Say yes to anything.
Great. Did you guys all get trading cards too? The dogs come with trading cards. This is a trademark of all therapy dogs I've found.
Yeah, no, we did. And I mean, I think it's a great idea. There are lots of challenges, though, especially in an emergency department as crowded as ours is, as busy as ours is. I mean, there are all kinds of issues with, children and staff who have allergies. I mean, so this is not like a magic bullet, and I'm sure that you have heard all of these issues and started to think about them. We've had child life in our ED for more than a decade and really couldn't function without it, and I think this is it's interesting that you're posing it as a trial between child life and therapy pets, as opposed to one being an adjunct to the other. I'm not sure it's either or.
Which actually is a really interesting question, is to me kind of when you're, so it's great to look at kind of the E4 is a great watch, really high reliability and validity versus kind of the discussion that we were having with Stephanie's stuff. You've got great data as to the accuracy of your measurements. One of the big questions to me is, I think there's not a lot of doubt that holding a pet is going to, for most people, decrease their stress and anxiety, as just witnessed. But the cost, and so my suggestion would be that you guys consider measuring some sort of a cost measure, because like I think about a lot of the mobile health work that I do, and one of my selling points is that in theory, it's cheaper. and more easily disseminated. And so if there were some way to kind of look at those, what would eventually be like a dissemination and implementation outcome, and to start thinking about that now, and maybe even to talk to some D&I people about doing this as some sort of a hybrid trial where you measure some of those things around kind of feasibility of the long-term practice. To me, that would be important stuff to add.
Thank you.
Yeah, good suggestion.
You can combine this with the microbiome project too, if you want to store samples.
Do you guys have any other questions or comments, suggestions? You all want to partner with us? All right. Is it only dogs? Right now, we're limiting it to dogs. That's really what's been approved at Riley Hospital. There's other hospitals that actually have like therapy ponies and some other animals as well. We're not moving into that. We're not there yet.
The bunny's cute.
Yeah, we have a space issue.
Yeah.
And our corporate sponsors support us, but our health facilities, there's no cost. We're all volunteers. So, and we do have, you see, we have Tommy and a bunny and a cat and mini horses and full-size horses. It depends on what the population is. And for health, it depends on what environment we're in. I worked in emergency 3 years with my dog, and if it wasn't suitable, it wasn't suitable. But if it was, we were there, so.
Are there pet partners? I mean, so one thing that I think about in the logistics is, are there pet partners in cities across the United States?
We are in all 50 states, 10 international countries, and Canada. It is considered the gold standard of therapy programs, which is why we're thrilled Kim called us, and Dr. Klein. We were here yesterday with some of our pets as well. The standard is different than all other therapy programs, to be honest. No metal, no costumes on the dog. We do the real deal. And you see the demeanor of these. You're not going to hear barking, jumping, licking. Nothing. And we write the protocols for different facilities. So where I go, it might be different with my active duty military versus my emergency room on Monday. So it really depends. But Pet Partners is everywhere, and I recommend starting with them because they have the strictest research and protocols.
And are you 24/7? So my next question is, my child life always disappears at 5 p.m. Are you available around the clock?
Most of my volunteers work full-time out of our program, so anything that's evening or weekends, we are better off. I've been places we are a second responder here in town, and you know October 1, 2 years ago was quite amazing. We deployed 400 hours within a few weeks, 2 in the morning. We were second responders, so you really want to work with a professional program. Benny, do you have anything to say? No. And it depends on the population. I've been called because we had a 12-year-old come in with a stroke, and Benny's a 2-time stroke survivor. There was no better thing than to bring this dog in and say, you can do this.
Okay, so I'm now going to put on my firearm injury hat, and I'm actually going to ask a question, which is, did you guys collect data when you responded after the shooting last year?
Did. We work with Trauma Intervention Program and Metro. We did not ourselves. I'm not Pet Partners corporate, but we certainly report to them. We're the Las Vegas chapter. But there are so many studies that Pet Partners has underscored in working with autism and Alzheimer's and you name it. But we were the first ones in Vegas to ever be in an emergency room or to work with the sex abuse division of the DA's office. We do all the secret things because we have the best animals and best handlers.
So I'm going to make a very separate proposal to you guys and to you because of the fact that you brought them here, which is I'm good friends with the woman who's the head of the trauma ICU here, Dr. Cools, who's a trauma surgeon in here in Las Vegas at the University of Nevada, and she was the responder. She was the trauma surgeon on call for the shooting, and she and I worked together on research. And I'm actually meeting her for dinner tomorrow night, and I would love to propose that we work with you to try to see if we can get data and look at the efficacy of dogs in preventing post-traumatic stress symptoms among survivors and among staff in the response to a mass shooting. Perfect.
What did you say? I was distracted by Benny. But
and then now we've got Sam. I said PTSD, and now Sam is in.
Your primary outcome measures for this is what, for the K word?
Could you repeat the
Or
question?
sorry, for your grant, the primary outcomes for the kids is what?
So it will be both a reported decrease in stress and anxiety and a physiologic decrease as well as what we're anticipating. So the families, though, like the parents, will do only the FACES scale. They won't have an E4 wristband because they're quite expensive. But what we've already found is that the parents are actually having a more significant decrease in the stress and anxiety than the children. But again, like the children that are have the greatest benefit are those with neuropsychiatric disorders like autism. And right now the students that are working on the project with me are also making field notes because some of this I can't exactly measure on these scales.
Right. That's cool. You could consider doing spits, at baseline and then in an hour or two to look at either epigenetic changes or look at probably epigenetic changes would be the best, but also look at other factors as well.
Sam wants biomarkers. So just for those who don't know, Sam has this huge NIH-funded study on biomarkers and psychophysiological data on folks after trauma, which is, yeah, he's good.
Thank you.
All right, you guys, thank you. So all of you in the audience, I'm going to make a plea. Those folks who were not up here presenting, or for those of you who have mentees, please have them apply next year. So the success of Lion's Den depends on the success, on the willingness of folks to stand up here and present. And I just really want to make the plea to all of you that you pass it on and let your mentees and friends and colleagues know to apply to present to us next year.